Good morning, everyone. Thank you so much for joining us today. I have the pleasure and honor to introduce our first guest speaker for today's Grand Rounds. Dr. Violet Lagari is an associate professor of clinical medicine in the Division of Endocrinology, Diabetes, and Metabolism at the University of Miami. She serves as the program director of the Endocrinology Fellowship Program and is section chief of endocrinology at the Miami VA Medical Center. Dr. Lagari has an interest in disorders of bone metabolism, where she has a dedicated bone clinic. Please give your undivided attention to Dr. Lagari.
Thank you so much. So excited to be here today. So I'm going to be talking about normocalcemic primary hyperparathyroidism. I have no disclosures, and these are the objectives for today. So I'm going to provide an update to the diagnosis and management of normocalcemic primary hyperparathyroidism, identify the complications, how to develop a medical management plan, and identify those patients who may be appropriate for surgical intervention who have normocalcemic primary hyperparathyroidism. So we're going to start off with two cases. The first case is a 66-year-old postmenopausal woman who was referred for hyperparathyroidism that was detected as part of her workup for osteoporosis. Her initial labs showed a calcium of 10.2, ionized calcium 1.2, PTH was 87, BUN and creatinine was 18 and 0.75. A 25 hydroxy vitamin D level was 35. 24-hour urine calcium was 67 milligrams. Her bone density T-scores showed minus 1.5 at the lumbar spine, minus 2.5 at the femoral neck, minus 1.5 at the total hip, and minus 1.7 at the distal radius. She had T7 and T8 vertebral fractures that were detected on X-ray after complaining of back pain. She had no dairy intake, and she was not on calcium supplements. She was taking 2,000 units of vitamin D3 daily. She was on hydrochlorothiazide for hypertension for the last year. She had received IV zoledronic acid, 5 milligrams, approximately 6 months prior to her initial evaluation. There was no family history of hypercalcemia or metabolic bone disease. The second case is a 59-year-old postmenopausal woman who was referred for hyperparathyroidism, also detected as part of her workup for osteoporosis. Her calcium was 9.7, and ionized calcium was 5.1, PTH was 121, BUN and creatinine was 21 and 0.9. A 25 hydroxy vitamin D level was 35. She was taking 1 to 2 servings of dairy per day, a calcium citrate supplement of 630 milligrams daily, and 4,000 units of vitamin D3 daily. Her repeat labs done 5 months later showed a calcium of 9.8, PTH was 112, a 25 hydroxy vitamin D level was 58, and a 24-hour urine calcium was 143 milligrams in 24 hours. She had no history of nephrolithiasis or fracture, lithium or hydrochlorothiazide use, or radiation exposure, no family history of hypercalcemia or metabolic bone diseases. Her T-scores showed a minus 2.8 at the lumbar spine, minus 2.6 at the femoral neck, minus 1.5 at the total hip, and minus 2.1 at the distal third radius. So first, let's just start off talking a little bit about the history of the parathyroid glands. So the parathyroid glands were first discovered by Sir Richard Owen in 1852 after he performed an autopsy on the great Indian rhinoceros that was kept by the Zoological Society of London. And at that time, he didn't name them, nor did he know the function of the parathyroid glands. It was years later that the parathyroid glands were named, and then even years after that, that the function of the parathyroid glands was discovered. So interestingly, the parathyroid glands are the last endocrine glands to have been discovered. So when we talk about the evolution of primary hyperparathyroidism in terms of what we have learned over the course of many years, over several generations, what we know is there are 3 distinct phenotypes of primary hyperparathyroidism. The first being what we know of the classic symptomatic primary hyperparathyroidism that was described prior to 1970. And that it involves marked hypercalcemia, osteitis fibrosa cystica, fractures, CKD, nephrolithiasis, nephrocalcinosis, super symptomatic. The um, the phenotype that was described after 1970 is what we know as asymptomatic primary hyperparathyroidism, largely because of the advent of the CMP, where calcium levels were detected incidentally, and hypercalcemia was being detected that way. So this is a disease of primarily biochemical findings with elevated calcium and elevated PTH, and bone density findings of osteoporosis that's more marked in the distal third radius, as I'm going to show a little bit later on. After 2000, this entity that we are coming to know as normocalcemic primary hyperparathyroidism is starting to be described more readily. This is a disease of elevated parathyroid hormone and normal serum calcium. Now, patients can be recategorized in in any one of these phenotypes as they progress with their disease, meaning if a patient with normocalcemic primary hyperparathyroidism who has normal serum calcium develops hypercalcemia, then they're thought to have asymptomatic primary hyperparathyroidism. And similarly, if someone with asymptomatic primary hyperparathyroidism develops a fracture or nephrolithiasis, then they get reclassified as having symptomatic primary hyperparathyroidism. Normocalcemic primary hyperparathyroidism was first recognized in 2008. It was in 2013 that the first diagnostic criteria were proposed. And then most recently, in 2022, at the 5th International Workshop, there's still insufficient evidence to provide guidance regarding management. Largely, it's felt that normocalcemic primary hyperparathyroidism is an early manifestation of classic hypercalcemic primary hyperparathyroidism. In order to make the diagnosis of normocalcemic primary hyperparathyroidism, you need to have persistently elevated PTH levels, at least for more than 3 months, normal albumin-adjusted serum calcium levels, and normal ionized calcium levels as well. As it stands, the hallmark of normocalcemic primary hyperparathyroidism, what you need to have is normal levels of both corrected and ionized calcium levels. If patients, again, as I mentioned before, if they progress and they end up with hypercalcemic values, then they get reclassified into classic hypercalcemic primary hyperparathyroidism. And as a general reminder, parathyroid hormone controls calcium and other mineral metabolism through the interplay of the 3 major organ systems. So when there's a sense of low calcium, the parathyroid glands kick in to produce parathyroid hormone, which work at these 3 organ systems to make sure that calcium is normalized, and make sure that calcium goes back into the normal range. So at the level of the bone, you get increased calcium resorption from the bone into the serum. At the level of the kidney, you get conversion of 25-hydroxyvitamin D to 1,25-dihydroxyvitamin D, and you get decreased excretion of calcium through the kidney. And at the level of the intestine, that increased 1,25-dihydroxyvitamin D results in an increased calcium resorption from the gut into the serum. All of this, again, it works in concert, everything together, in order to make sure that serum calcium levels are always maintained in a very tight, narrow range. When we talk about normocalcemic primary hyperparathyroidism, the main thing that everyone needs to do is to exclude causes of secondary hyperparathyroidism in their differential diagnosis. So the first and most important being vitamin D deficiency. So the most recent international workshop defines having a cutoff of 30, a 25-hydroxyvitamin D of above 30, in order to exclude secondary hyperparathyroidism in the differential of normocalcemic primary hyperparathyroidism. Chronic kidney disease, so having a GFR above 60 excludes CKD or renal disorders as a differential for secondary hyperparathyroidism. And just as a reminder, how CKD results in elevated parathyroid hormone is through phosphate retention, which can increase PTH, but also lead to an increase in FGF23, which results in decreased 125 hydroxy vitamin D, which can increase parathyroid hormone. There are a variety of medications that can also cause secondary hyperparathyroidism. So bisphosphonates and denosumab are very notable in that they can decrease serum calcium levels and increase parathyroid hormone. And that increase in parathyroid hormone can take up to several months to resolve. Diuretics, so furosemide specifically, can, through the action of increasing calcium excretion, can lead to an elevated PTH. Hydrochlorothiazide increases renal absorption of calcium. It used to be thought that that resulted in elevated PTH, but there is newer data to suggest that that actually is not the case. Lithium, we know that lithium can work to alter the set point for receptors that sense calcium in the parathyroid chief cells. And interestingly, sodium glucose cotransporter 2 inhibitors, so these very common medications that we use nowadays to treat diabetes, have been implicated in hyperparathyroidism by causing phosphate retention, which can increase FGF23, lead to decreased 125 dihydroxy vitamin D, and increase PTH. Hypercalciuria, so having more than 250 milligrams of calcium in the urine in 24 hours for women, or more than 300 milligrams in 24 hours for men. Low calcium intake can do this as well. And interestingly, when you put a patient on and you prescribe, dietary or supplemental calcium to correct hyperparathyroidism, it can also take several months for the PTH to resolve and for you to see that normalization of parathyroid hormone. Also decreased calcium absorption. So I have two examples there, being bariatric surgery and celiac disease, that can result in micronutrient and specifically calcium deficiency and difficulty with calcium absorption that can cause hyperparathyroidism that way. So what do we know about the epidemiology of normocalcemic primary hyperparathyroidism? Basically, it's a little bit all over the place. So the prevalence rates vary quite widely, and this is in part due to the fact that there are lack of rigorous diagnostic criteria, but also it has to do with the setting in which these studies are conducted. So the community dwelling studies, for example, where it's not as common for patients to have parathyroid hormone levels drawn as part of just workups for, let's say, osteoporosis or whatever the case may be, the prevalence rates may tend to be lower in those settings versus larger academic or tertiary referral centers where you'll have specific referrals for parathyroid hormone elevation. The prevalence rates will be a little bit higher in those settings. As far as complications of normocalcemic primary hyperparathyroidism, it's very similar to what we see with asymptomatic primary hypercalcemic primary hyperparathyroidism. So osteoporosis and nephrolithiasis seem to be the most common complications. And so I have now I'm going to switch gears and talk a little bit about the bone mineral density findings. So this is what you see in classic hypercalcemic primary hyperparathyroidism. So when we check bone density studies in our patients with classic hypercalcemic primary hyperparathyroidism, you'll see most commonly reduced bone mineral densities at the radius. And this is what is classically described, and it's thought that hyperparathyroidism is destructive. It's catabolic to cortical bone, which is the site that comprises the radius, that the radius is comprised of most readily. more so than the other sites, which are comprised more of either a combination of cortical and trabecular bone at the hip and at the lumbar spine, which is primarily trabecular bone. In patients who have normocalcemic primary hyperparathyroidism, however, this difference is not quite as marked. So there may be a slight reduction in the distal third radius bone mineral density, but it's not quite as pronounced as you see in patients who have classic hypercalcemic primary hyperparathyroidism. And what we know regarding the modern clinical profile of mild hypercalcemic primary hyperparathyroidism based on these large landmark studies, and you'll see this here very clearly and very and alluding back to my very first comments in one of the initial slides, is that over the course of time, whereas hypercalcemic primary hyperparathyroidism used to be a very symptomatic disease with nephrolithiasis and overt skeletal disease. Over the course of many years, generations, what we know now as mild hypercalcemic primary hyperparathyroidism, this is largely an asymptomatic disease with a lot less nephrolithiasis and virtually no overt skeletal disease, and less hypercalciuria as well. With regard to the natural history of normocalcemic primary hyperparathyroidism, from following patients in the clinical setting, you know that sometimes patients progress and they might develop overt hypercalcemia, and sometimes it takes, sometimes you don't see that, and that's basically what the studies have shown. So this is not quite as well teased out. So the studies that have been done looking at monitoring of patients over the course of years, some patients have gone on to progress to hypercalcemia and some have not. So, at this point, it's still somewhat inconclusive. But again, it's felt that normocalcemic primary hyperparathyroidism, when you exclude the secondary causes that we talked about earlier, is a disorder that is felt to be an early manifestation of classic hypercalcemic primary hyperparathyroidism. With regard to medical management, the data has shown that that alendronate does have modest increases in bone mineral density, specifically at the lumbar spine, in normocalcemic primary hyperparathyroidism. One of the more interesting findings is a small unblinded pilot study of 6 patients with normocalcemic primary hyperparathyroidism using cinacalcet at a dose that was sufficient to decrease PTH levels. This study showed that in this particular population, there was a decrease in the number and diameter of kidney stones, suggesting a very interesting role for cinacalcet in this setting, particularly if you have a patient who has normocalcemic primary hyperparathyroidism, may not be a surgical candidate, is having kidney stones. This might be a nice option. So who is it that we consider to refer to surgery with normocalcemic primary hyperparathyroidism? So if you have a patient who has established long-standing elevated PTH values, who is symptomatic with kidney stones and or fractures, who has a clear target that has been identified on imaging, and you know that you have a surgeon that you trust, this is the ideal candidate for referral to surgery who has normocalcemic primary hyperparathyroidism. With regard to what is the ideal imaging modality, specifically talking about normocalcemic primary hyperparathyroidism, so 4D CT has fared the best relative to ultrasound and scintigraphy. This is obviously not very practical because it's the most difficult study to get coverage for in terms of insurance approval. But just to know that this might be the best one. I mean, still should, if you are considering surgery, go with one of the more common, less expensive options initially. But this is what the studies have shown. Interestingly, In patients who have undergone normocalcemic primary hyperparathyroidism surgery, these patients have been found to have a higher degree of multiglandular disease. So this complicates the scenario, particularly for a surgeon who's going in, thinking maybe that there is single gland disease, and in fact, it ends up being multiglandular. And just as a side note as well, it seems also that in classic hypercalcemic primary hyperparathyroidism, there is this trend towards having multiglandular disease, whereas it used to be that it was more common just to have a single adenoma etiology of the primary hyperparathyroidism. So I'm not sure if this is related to normocalcemic primary hyperparathyroidism in and of itself, or it's just a trend that we're seeing overall with the natural evolution of this disorder. Adenomas tend to be smaller in normocalcemic primary hyperparathyroidism relative to hypercalcemic primary hyperparathyroidism. And because of the fact that there is a higher risk of multiglandular disease, and also a slightly higher risk of parathyroid hyperplasia in this disorder, it's more common for surgeries to get converted to foregland exploration, which is obviously more challenging and has higher surgical risk. With regard to post-surgical studies, we know that patients tend to have an increase in their bone mineral density. And with regard to the risk of nephrolithiasis after parathyroidectomy, this is the same whether you're dealing with normocalcemic primary hyperparathyroidism or overt hypercalcemic primary hyperparathyroidism. Surgery does not entirely resolve the risk of having repeat episodes of nephrolithiasis. So this is something that should always be counseled. You should counsel your patients about this, that if you send them for parathyroidectomy, that there's no guarantee if they have a history of symptomatic nephrolithiasis that this will entirely resolve. And then with regard to other endpoints of primary hyperparathyroidism, whether we're talking about normocalcemic primary hyperparathyroidism or even hypercalcemic primary hyperparathyroidism, the studies are basically inconclusive with regard to endpoints of quality of life, glucose homeostasis, blood pressure, cholesterol, and the list goes on and on. So with regard to specific normocalcemic primary hyperparathyroidism, there aren't many studies, they're small, and so we can't draw very hard and fast conclusions. So to end with our cases, the first case that I presented, the patient increased her calcium intake through diet and a supplement of 500 milligrams of calcium. She had repeat labs done 4 months later. Her calcium was 9.9, ionized calcium was 1.2, parathyroid hormone was 63, BUN and creatinine was 35 at 33.8. So a diagnosis of hyperparathyroidism secondary to low calcium intake with subsequent resolution was made, and the PTH remains in the normal range after the increased calcium intake with a year of monitoring. The second case, the patient went on to have a parathyroid ultrasound and a sestamibi scan, which demonstrated a left superior adenoma that measured 1.4 centimeters. She underwent surgery. The PTH levels failed to fall after removal of the left superior gland. The surgery was converted to a bilateral neck exploration, and the patient underwent subtotal parathyroidectomy. The pathology confirmed parathyroid hyperplasia in that case. The PTH levels remained in the normal range following surgery, ranging from 27 to 54. And the patient remained in the osteoporosis range and was placed on IV zoledronic acid. So in summary, how do we evaluate normocalcemic primary hyperparathyroidism? So we want to monitor the serum total, the ionized calcium, and exclude secondary causes of hyperparathyroidism, which we discussed, vitamin D deficiency, CKD or renal disorders, drugs, malabsorption, hypercalciuria, and disorders of phosphate metabolism. What medical management can we offer? So bisphosphonates in particular have been studied in the setting of normocalcemic primary hyperparathyroidism, but any anti-resorptive therapy is definitely a practical option to consider. Also, cinacalcet, based on that one small study for kidney stones, can be considered. And who should we refer to parathyroid surgery? So this is the big one. So patients who have a clearly established diagnosis with longstanding elevated parathyroid hormone symptoms and a clear target with localization studies and an experienced surgeon are the best candidates for surgery. But I would caution everyone to take a very conservative approach and really consider monitoring these patients to see if they manifest overt hypercalcemia, which might lead to a clearer target with repeat imaging and might lead to a better outcome surgery wise. And that's it. Thank you. Any questions?
Thank you, Dr. Lagari. That was two very interesting cases of a very important topic. So, just a comment and a question. So, the PTH ranges from, I think he gave us in most labs, 16 to 77. That's an enormous range for the measurement of a hormone. Even something as broad as TSH is also a factor of 10, but this is considerable. So it must mean that there's lots of variation in the normal physiology in the population that could attribute to such a wide range of, quote, normal values of PTH. And what's interesting, so I just put that out there, but my question to you is, how long do you follow these patients? Because there's a study that shows 25% of patients with this phenomenon of normocalcemic primary hyperparathyroidism will actually have normal PTH values if you follow them long enough. And yeah, they can develop osteoporosis because if they're female and they get old for other reasons. So how many times or how many years do you actually follow these patients with multiple labs and so forth until it reverts to normal or you decide to do something?
So just to comment on your very, very astute point. So you can have, and you'll see, everyone here will see this, where you'll have patients who have overt hypercalcemia and parathyroid hormone levels that are like, quote, in the normal range. And this doesn't, so as long as you have detectable parathyroid hormone, unless it's suppressed, this is considered, a variant of primary hyperparathyroidism. That is PTH that's detectable on an assay. So that's a very important point. And then to your point about how long do I monitor these patients, I mean, it's really variable. If I have a very mild case, I mean, I monitor them indefinitely. If I have a very, and I've had, patients who have symptomatic kidney stones, I think it's worth, it's worth considering surgery in those cases just to see if there is a benefit in terms of surgery. I mean, there may or may not be, like I mentioned, but I think that you really have to think long and hard because these surgeries are not without risk, as you already saw. And it's not to say even like the risk of hypocalcemia, and which can most definitely occur. And more than that, psychologically, if they remain with hyperparathyroidism after the surgery, these patients, it's kind of disconcerting, for them. So you always have to weigh all of these factors.
Dr. Bocanegra, you have a question in the chat. You want to unmute yourself and ask it? And then...
Yes, thank you, Dr. Vice. My question is in relationship to the occurrence of CPPD and hyperparathyroidism, and what will be the outcome of CPPD after the treatment of hyperparathyroidism?
Sorry, can you, what is CPPD? What does that stand for?
Calcium pyrophosphate disease, pseudogout.
So that's that's an interesting question. I'm not exactly sure what the studies are with regard to that specific outcome. My best educated guess is that it might be similar to nephrolithiasis, that there may not be complete resolution, but I'm not exactly sure. I'd have to look at that and get back to you.
Thank you.
Thank you. Let's move on to the next speaker. Thank you, Dr. Lagari. That's excellent. Dr.
Okay,
Katz.
so our next speaker is going to be Dr. Alexis Katz, who's a voluntary assistant professor of medicine in the Division of Rheumatology at the University of Miami Miller School of Medicine. Dr. Katz completed her residency and fellowship training at the Cleveland Clinic. She's a clinician with a focus on inflammatory arthritis and connective tissue diseases. Dr. Katz is actively engaged in medical education across all levels of training and has a strong interest in advancing rheumatology education and clinical care. Please give your undivided attention to Dr. Katz. Thank you.
Thank you for that lovely introduction. Can everybody hear me? I'm okay.
Yes.
Okay, perfect. Thank you. So today I'm going to focus on crystal arthropathies. We're going to take a sort of broad approach looking at each of the types of crystal arthritis, some cases that are pertinent to that, and the management of each of these scenarios. We're going to approach it in a case-based approach. So here you can see the 5 cases that we're going to focus on. And in the interest of time, I'm going to skip through that part and we'll just talk about them as we go. The first case is a patient, a 58-year-old male patient who has a history of right knee swelling, which is acute in onset, low-grade fever, leukocytosis, CKD stage 3. They're on diuretic regimen, and they have a serum uric acid level of 4.8. The priority here is to treat the joint as septic until proven otherwise, and for that reason, joint aspiration is considered mandatory. However, crystal arthritis and infection can be coexistent, and that's especially true in immunosuppressed or older patients. And so even if you get the crystal analysis back first and it's positive, you still need to wait for the culture to make sure there's no infection present. As noted for this specific patient, the uric acid level was low, but that on its own does not exclude the diagnosis of gout. And so for that reason, we do look at uric acid levels, but they're frequently suppressed during an acute flare-up. And the mechanism for this is felt to be related to cytokine-mediated uricosuriia, as well as redistribution of the crystals into the joint space, and that can cause a falsely low uric acid level in the serum. So the urate should be used as a chronic risk marker, not as an acute diagnostic test. And similarly, high uric acid level does not diagnose gout. It's frequent that we find patients who have chronic hyperuricemia and they may never develop clinical evidence of gout. Here you can see the classic needle-shaped, negatively birefringent monosodium urate crystals. Again, as mentioned, it's still important to send cultures if there's concern for infection. When it's not applicable to be able to do a synovial fluid aspiration, there's now dual energy CT, which uses dual X-ray energy levels to distinguish urate from calcium. And so as you can see in the image, the urate is highlighted in a bright green color. It's particularly helpful in patients with a somewhat atypical presentation, or again, if the aspiration cannot be performed, but does not take the place of synovial fluid analysis if infection is of concern. Around the nail beds, it's not uncommon to see some artifact, which sometimes leads to false positivity. So it's important to interpret it with caution. Most of us are familiar with acute gout management options, NSAIDs, colchicine, glucocorticoids. When you're making your decision about which option to use, a lot of times these patients also have other comorbidities that need to be accounted for. For monoarthritis, as long as infection's been evaluated and excluded, it's acceptable to do intra-articular glucocorticoid injection. And now more recently, we're using IL-1 blockade with anakinra, which is especially helpful in inpatient setting when the patient has multiple comorbid conditions. So as an example, as we've experienced, we usually see patients who are admitted to the hospital with some sort of infection. They have poorly controlled diabetes and CKD. And in that setting, we struggle to say, we don't want to give them NSAIDs. We don't want to give them steroids. They may not tolerate colchicine. So that's a good situation to consider anakinra. Of course, you need to coordinate with the infectious disease team if there's infection as part of the clinical picture. But usually they'll allow 3 to 5 days of treatment, which is most often adequate to control a flare-up, even in patients where infection is of concern. The second case is a focus more on chronic gout management. So here we have a 62-year-old male patient with visible tophi. He's been chronically inflamed. He's had polyarticular flare-ups and functional limitation. His serum uric acid level is 9.8. The goal is to identify and manage these patients aggressively, ideally before they develop significant joint damage. But unfortunately, we are still seeing some patients who have been, missed, or they're non-adherent, and they're coming in with these, clinical presentations with significant tophi. Sometimes these punched out or rat bite lesions, as you can see in the figure on the left, or more advanced, severe, erosive, and damaging arthritis, as you can see on the right-hand side. And you can imagine that the patient on the right, even if we debulk all the soft tissue tophi, is going to have functional limitations related to the destructive arthropathy. So the goal to treat these patients is to treat aggressively to a target uric acid level of less than 6 in patients without tophi and less than 5 in patients with tophaceous disease. The uric acid targets are grounded more in crystal biology rather than head-to-head trials. We know that below 6 milligrams per deciliter, the crystals dissolve and the clinical outcomes improve. And so for more severe disease, we push lower to accelerate that process. The key here is to monitor patients serially in order to make sure the necessary dose adjustments are made to get them to their goal uric acid level. And so when should it be initiated? In high-risk patients, we need to be identifying them sooner and putting them on disease-modifying therapy right away, even if they've only had one flare-up. So these high-risk patients are patients with CKD greater than or equal to stage 3, a uric acid level greater than 9, urolithiasis, tophi, or radiographic joint damage. If they don't have any of those features, it's acceptable to wait until after they've had 2 or more flare-ups in a single year. It's important to note that the ACR 2020 guidelines also recommend starting urate-lowering therapy during an acute flare rather than waiting for the flare to resolve, and that is provided that the patient is on anti-inflammatory therapy at the same time. Allopurinol remains the first-line uric acid lowering therapy. The key, again, is to titrate to the appropriate target. So for my patients, generally, I start at 100 milligrams if they don't have CKD, or 50 milligrams if they do have CKD. They're advised to recheck their uric acid level every approximately 3 to 4 weeks so that we can make the appropriate dose adjustments. And I continue that process until they're at their goal uric acid on at least 2 occasions. This is in conjunction with prophylactic medications, which we'll discuss shortly. There is an association of allopurinol with severe cutaneous reactions like SJS-TEN. It's relatively rare, but it carries a significant morbidity and some mortality risk. And so it's important to screen high-risk individuals. So it's an HLA-B5801, and you want to check it in Southeast Asian patients and African-American patients as well. If it's abnormal, we have some other options that we will discuss shortly. So historically, there was a concern that higher allopurinol dose may worsen kidney function and may lead to us to underdose patients, but that concern has been largely debunked. So the dose is determined by urate target, not a fixed max. And the takeaway is that allopurinol is safe to use in CKD and should be titrated to the appropriate urate level. What about asymptomatic hyperuricemia? So the currently available evidence suggests not to treat. However, there are some ongoing studies investigating special circumstances where it may be useful. Hyperuricemia is strongly associated with CKD progression, but the current evidence does not support a causal role or treatment of asymptomatic hyperuricemia, even in patients with kidney disease. So we treat gout, we don't treat asymptomatic hyperuricemia. There have been randomized placebo-controlled trials like the CKD FIX and PEARL studies, which showed that lowering urate with allopurinol did not slow CKD progression. There was an increase in urinary albumin excretion in the PEARL study, which led to some concerns about safety. But due to the lack of evidence, the KDIGO 2024 guidelines did not recommend treatment of asymptomatic hyperuricemia. And so again, the takeaway is to treat gout aggressively in CKD, but not to prescribe allopurinol for renal protection alone. The other available urate-lowering therapy options include febuxostat and probenecid. Febuxostat is used more commonly, especially in the patients who are HLA-B5801 positive. Both of them require relatively preserved renal function, so that's one limitation, and probenecid should be avoided in patients with nephrolithiasis. There had been some concerns about cardiovascular risk related to febuxostat, which we're going to review in just a moment. So the cardiovascular concerns with febuxostat came primarily from the CARES trial in 2018, which studied over 6,000 patients with gout and established cardiovascular disease. And while they met their primary composite endpoint that febuxostat and allopurinol were, both acceptable to use, there was a signal for increased cardiovascular and all-cause mortality in the febuxostat group, which led to an FDA boxed warning. However, there were significant methodological issues with the CARES trial. 45% of the patients discontinued follow-up, which created a substantial information bias. And when private investigators traced the patients lost to follow-up, the signal was no longer statistically significant. The FAST trial in 2020 was a European study that did not replicate the mortality signal and found that febuxostat was non-inferior to allopurinol and had no increased cardiovascular risk. The methodology here was much more sound and the follow-up was much better. So believably, that's probably the correct answer. And so usually I will still, if I need to, use febuxostat, but in the context of shared decision-making with the patient. So why does urate-lowering therapy fail? Urate-lowering therapy fails most often because of how we use it and not because it doesn't work. The most common reason is that we underdose patients, and the common concern is that we see these patients who were started correctly on urate-lowering therapy, but for whatever reason, the provider did not increase the allopurinol dose to adjust for their uric acid level, or the patient is lost to follow-up and just remains on this sort of low dose of allopurinol. And in that setting, they usually continue to have flare-ups, which of course makes them believe that the medication doesn't work for them, when in reality, if they were able to get to their target uric acid level, they would do better and they would be fine. So it is important to explain the risk of flaring up during urate-lowering therapy initiation. That is an expected outcome. We're mobilizing the crystals, and that increases their risk of flare-ups. In order to prevent that, we usually prescribe a prophylactic agent in addition to the urate-lowering therapy so as to prevent these flare-ups from happening. So the options for prophylaxis are actually fairly similar to those we use for acute flare-ups. So colchicine, NSAIDs, low-dose prednisone. In general, I usually continue prophylaxis until the patient has been at their goal uric acid on at least 2 occasions. Prophylaxis is not optional. It's in fact part of starting urate-lowering therapy successfully. Oversuppressing uric acid has been of concern as well. Usually the concern is when you get to a uric acid of less than 3 milligrams per deciliter. And there were some concerns for increased mortality, potential neurodegenerative effects, including an association with increased risk of Parkinson's, Alzheimer's, and cognitive decline, and a loss of antioxidant protection. So multiple large observational studies demonstrated a U-shaped association with serum uric acid and all-cause mortality, with inflection points typically around 5 to 6 milligrams per deciliter. Both high and low uric acid levels were associated with increased mortality for all-cause mortality. The uric acid also serves as an important endogenous antioxidant and protects us against oxidative stress. So lowering uric acid levels substantially may compromise that mechanism. The Colcott and Lodoco 2 studies demonstrated that low-dose colchicine significantly reduces cardiovascular events in patients with cardiovascular disease. In contrast, the Clear Synergy study found that there was no benefit when colchicine was initiated in acute STEMI patients. The divergent results could be explained by the differences in patient population, trial design, or timing of colchicine initiation. A 2025 Cochrane meta-analysis of more than 22,000 patients found with high certainty that colchicine reduces MI and stroke, but had little effect on cardiovascular mortality. And so this is where gout overlaps with systemic inflammation. Colchicine is no longer just a gout drug. It may be used for other treatment. Cipolletta et al. Demonstrated that gout flares are associated with a transient, nearly 2-fold increased risk of cardiovascular events in the 60 days following a flare. And so this emphasizes that gout is not just a joint event, it's a systemic inflammatory stress issue. And it also emphasizes the rationale for aggressive treat-to-target urate-lowering therapy. So what about diet? So we always emphasize this low purine diet to the gout patients. But the truth is that lifestyle, although it modifies the risk, does not usually achieve the target. You really need to rely more heavily on the medication to get there. Diet alone has been found to lower serum uric acid only by about 0.5 to 1 milligram per deciliter. And again, that's generally not enough to control gout in most patients. So typically I do counsel patients about dietary changes for low purine diet, but I clarify that the medication adherence is key and that once the goal uric acid level is achieved, they may be able to slowly reintroduce some of the foods back into their diet in moderation. So again, gout does extend beyond the joint. It signals broader cardiometabolic disease, and so our management does need to reflect that. I am going to highlight some more advanced gout therapy, which is pegloticase, which is a relatively newer option for treatment of advanced tophaceous or severe refractory disease. Pegloticase is an IV infusion of a recombinant uricase, which rapidly lowers uric acid and debulks the tophaceous deposits. The patients are concomitantly treated with immunosuppression to prevent antibody formation because the development of antibodies actually drives loss of efficacy of the drug and potentially severe infusion reactions. And so the uric acid has to be monitored before each dose of the medication, and if it's trending up, the medication has to be discontinued. At the bottom of this slide, you can see the dramatic changes that occur in a patient who is on pegloticase. So you can see both on the sort of clinical picture, but also on the dual energy CT, sort of the tophi melting away. And that's very typical to see these sort of pictures before and after for these patients. Transitioning here to CPPD. So the third case is a 72-year-old female presenting with symmetric MCP and wrist swelling with associated morning stiffness. The RF and CCP are negative. It's very tempting to label this person as seronegative RA, but it's important to recognize that pseudo-gout can also present in a pseudo-RA sort of presentation. In the X-ray here, you can see the chondrocalcinosis and the triangular fibrocartilage. For pseudo-gout, joint aspiration is still very helpful. Here you can see the rhomboid shape weakly positively birefringent crystals. However, the crystals alone are not enough to make the diagnosis. It's also necessary to have a clinical syndrome compatible with pseudo-gout. Another common area to see chondrocalcinosis is the cartilage of the knee. However, again, chondrocalcinosis on its own does not equal symptomatic CPPD. So chondrocalcinosis is common and increases with age. By the age of 80, about 30 to 40% of patients will have evidence of chondrocalcinosis, most often in an asymptomatic way. So we have touched already on the pseudo-RA presentation of pseudo-gout, but there's a number of other clinical phenotypes associated with pseudo-gout. I'm going to touch on a couple of them here in more detail. So regarding the management first of CPPD, it actually mirrors gout management. So it's NSAIDs, colchicine, glucocorticoids. For chronic pseudo-gout management, we're focusing more on prophylaxis and treating any metabolic drivers. There's actually no role for urate-lowering therapy and nothing equivalent to urate-lowering therapy for the crystals for CPPD. IL-1 inhibitors are being used more frequently, both for acute and chronic CPPD management. But patients don't really prefer them for long-term just because they're daily injectable and they're pretty uncomfortable. CPPD can also present in a pseudo-PMR fashion with bilateral shoulder and hip girdle pain and stiffness, elevated acute phase reactants. But it's important to think of CPPD in patients with suspected PMR who may not be responding as you would expect to a steroid taper, or those who have atypical features such as like a peripheral inflammatory arthritis. In younger patients or those with severe refractory disease, an investigation to look for secondary causes is necessary. The lab investigation usually includes screening for parathyroid and thyroid disease, hypomagnesemia, hypophosphatasia, and hemochromatosis. And in patients who have family history of CPPD or those who the other testing is negative, but they have more severe disease, sometimes we'll screen for ONC gene mutations. Our fourth case is an elderly patient presenting with severe neck pain and headache, fever, and elevated inflammatory markers. The initial concern would typically be for meningitis, but of course, the infectious workup having been done and being negative, you then need to consider Crown-Dens syndrome. So Crown-Dens syndrome can be caused by either CPPD or basic calcium phosphate deposition disease when the crystals deposit around the dens. Here you can see the CT findings of the deposition of crystals around the dens. The diagnosis can be missed without a CT and can also be missed by the radiologist if they are not aware that that's on the differential. And the last case that we'll talk about today is a patient presenting with acute and severe shoulder pain, limited range of motion. There's usually radiographic evidence of calcific tendinitis, which usually is periarticular in nature. And this is a representation of hydroxyapatite or basic calcium phosphate deposition disease. BCP is often clinically dramatic, but microscopically silent, mainly because the crystals, although can be identified in the synovial fluid, require alizarin red to be visible. They can also present together with CPPD crystals. So sometimes when you see the CPPD crystals, you think the diagnosis is made. And then if you look further, you may be able to also see the BCP crystals. Here we can see the radiographic calcific deposits supporting the diagnosis of BCP disease. The presentation can be acute and self-limiting, but there's also a severe destructive arthropathy associated with this called Milwaukee shoulder. Here you can see what Milwaukee shoulder looks like. You can see in this x-ray that the glenohumeral joint has been essentially destroyed and there are periarticular soft tissue calcific deposits. The initial treatment is usually NSAIDs, but the patients can frequently require steroid injection. They need some physical therapy. And for more severe cases, they will require either barbotage or sometimes joint replacement. It's also important to recognize steroid crystals in synovial fluid. They can mimic gout or pseudo-gout under polarized light. So it's especially important to ask those patients if they've had any recent history of injection to avoid misdiagnosis. Here you can see the high-yield pitfalls. So again, crystals do not exclude infection. So if there's ever a concern, culturing is necessary. A normal or low uric acid level during a flare-up is common, so it does not exclude gout. Allopurinol underdosing is unfortunately still quite common and quite harmful to these patients. So again, we need to focus on treating patients to target. Chondrocalcinosis is often incidental, especially in older patients. Steroid crystals can mimic pathologic crystals, so just to be aware of that. And the take-home messages for today's talk, it's important to aspirate acute monoarthritis. Infection is always the most important thing to rule out. You want to treat the gout to target using urate-lowering therapy and starting early in high-risk patients. Make sure to screen your patients for HLA-B5801 if they're in high-risk groups, which again are African American and Southeast Asian patients. CPPD and BCP have diverse mimics, so it's important to recognize the patterns and use the guidelines, but make sure to account for the patient's comorbid conditions and the context. These are my references for today and the key clinical trials, and I would be happy to take questions.
Thank you, Dr. Katz, for that whirlwind tour through arthropathies associated with crystal deposition. That was quite interesting and informative. I appreciate it very much. Let me ask a question about, with a practical question of approach to an elderly patient who's got multiple comorbidities. And we know things that, like colchicine, for example, has a high incidence of diarrhea and so forth in the elderly, and that could make it worse than the disease that you're trying to treat. What's your recommendation, and how do you approach the elderly patient with multiple comorbidities, let's say in CPPD?
So that one is kind of challenging, especially if they're having recurrent flare-ups. If it's monoarthritis and they don't have other, comorbid conditions that would preclude it, doing a joint injection to the affected joint might be the safest option because it would keep sort of things locally rather than systemic. If that doesn't work or it's polyarticular, sometimes just using a very low dose of colchicine, like 0.3 or every other day dosing is sometimes effective. Some patients, if they avoid dairy products while they're on colchicine, that actually reduces the diarrhea episodes. So you can, see if they can avoid lactose and if that sometimes helps. Otherwise, baby dose of prednisone, but obviously that has its own repercussions.
And so there's no way to predict in advance which is the safest or most efficacious.
No, I wish, but no.
Okay, well, thank you.
Sure.
Any other questions for those of us online? Nina had a question in on it. Nina, do you want to unmute yourself and ask your question? She can't unmute. Well, I can read what she says, so it'll be else. So CPPD has the same treatment, but is different to gout in the setting of absent systemic inflammation.
I'm not sure if I necessarily understand the question, but I'll do my best to answer it. So I suspect she's discussing the treatment sort of in general. So CPPD, because it doesn't have an equivalent medication that lowers the crystal count, these patients tend to deal with more chronic sort of smoldering inflammatory issues because we're not really treating the underlying problem. We're giving them management of symptoms, essentially. And so the focus is mostly on trying to control it in that setting. But from a gout perspective, if you're having a patient with chronic inflammatory changes from that should be manageable. Those patients should be on urate lowering therapy. And for the most part, once they get to their goal uric acid, the symptoms should be minimal to none. So it's important to make sure that they're actually getting to that goal.
Okay. Oh, Dr. St. Ange, you have your hand up.
Yes, thank you. I appreciate the review of the crystal arthropathies. The question that I have in terms of CPPD, is it also associated with kind of metabolic, cardiometabolic effects and risks similar to gout? Should we be expecting the same kind of constellation of concerns?
Yeah, so that's an excellent question. And I did not find that in the literature when I was reviewing. So it might be an area that still needs further exploration. In theory, because it's also activating the inflammasome and causing all of this, inflammatory milieu, you would suspect that it would also increase those similar, risk factors. But I did not find that when I did my review.
Thank you.
Sure.
Thank you. Thank you, Dr. Katz, and thank you, Dr. Lagari. I remind everyone to look at the chat and fill out the form in order to get MEC and MOC. And those of you who are beginning a celebration of Passover, I wish you all a joyous and peaceful holiday. And those of you that are not, have a great week. Take care of yourselves and each other. And we'll see you next week in person and in Zoom. Take good care, everyone.
Thank you.